I'd like to welcome you to the Medical Center Hour. This is the University of Virginia's public forum for medicine and society in conversation. The Medical Center Hour is brought to you each week by the School of Medicine's Center for Biomedical Ethics and Humanities, and I'm Marcia Day Childress with the Center for Biomedical Ethics and Humanities. Today marks the start of the Medical Center Hour's 40th season of continuous production. It was in 1971 that this forum, the brainchild of former medical school dean Tom Hunter and the eminent visiting ethicist Joseph Fletcher, went from being an occasional series to become week in, week out, a regular part of the life of this academic health center, the university, and the Charlottesville community. Even now, 4 decades later, the Medical Center Hour remains a special site of robust cross-disciplinary conversation on often provocative and evocative issues related to health, medicine, and society. As the only regular conference of the School of Medicine that's open to the whole university and the public, we're challenged to keep our programs wide-ranging, thoughtful, vibrant, and stimulating for a very diverse audience. As we start our 2011-2012 season, we're very grateful for the School of Medicine's support. We're also really grateful for you, our audience, for your presence and, importantly, for your lively contributions to the 20 programs we're going to present this year, 10 this semester, 10 in second semester. Our fall program lineup is on our center's website, the link for which is in your handout. And I'd remind you that these are quite literally your programs. Your voices and your views are a vital part of every session, always in the closing minutes of the hour, sometimes throughout the hour. So we welcome you to this season as our partners in what should be some rich and probing conversation. You can also tune into the Medical Center Hour on local TV. You'll find us on Comcast Channel 13 on Wednesday evenings at 8 o'clock, 3 weeks after the live presentation. And more conveniently, perhaps, our programs are on YouTube on a dedicated Medical Center Hour channel. That link is also in your handout. And usually the recordings get posted to YouTube within a couple weeks of the presentation. Those of you who are eligible for continuing education credits, those are made available on a quarterly basis through the Continuing Medical Education Office on an online system. And you should sign up at the table outside the auditorium so that the CME office has your contact and attendance information. There's one more bit of housekeeping. I'd like to gratefully acknowledge the support of the John F. Anderson Memorial Lectureship Trust for many of the Medical Center Hours we'll bring you this academic year. These programs, including today's program, will be designated John F. Anderson Memorial Lectures. And I'd just like to tell you quickly a little about Dr. Anderson. He was an 1895 medical graduate who had himself an illustrious and productive career in medical research and public health. With a gift to the School of Medicine, he sought to assure this medical community that had nurtured him of an ongoing forum at which to consider the latest developments in medical science and public health and their impact on society. As a young physician, he had worked in U.S. government service at home and abroad. He was the first to describe Rocky Mountain spotted fever and to identify the wood tick as the probable carrier. He standardized diphtheria and tetanus antitoxins, investigated tuberculosis-contaminated milk in the marketplace, and improved our understandings of measles, typhus, and polio transmission. He sounds like a one-man CDC. In 1909, he became director of the U.S. Public Health Service's Hygienic Laboratory. In 1915, he left government service to lead E.R. Squibb and Sons Research and Biological Laboratories. When he retired in 1946, he was a vice president at Squibb. He died 53 years ago this month at the age of 87. It's appropriate that we start our new year with another alum of the School of Medicine, who, even as a young physician, has had significant impact in the world of medicine and on the health of the public. We welcome today Dr. Samuel Hughes Melton, family physician and president of the rural community-based practice Sea Health in Lebanon, Virginia, 4 hours drive southwest of here. A 1993 medical graduate and also an alum in 1996 of our family medicine residency program, Dr. Melton has been honored by his professional society, the American Academy of Family Physicians, as the 2011 Family Physician of the Year. His contributions figure in the domain of healthcare delivery, especially provision of care to the medically underserved, of which there are many in the southwest reaches of the Commonwealth. His talk today will provide some insight into how he and his many colleagues, many of them also UVA grads, work in and work with their community, how they've learned to stretch themselves to serve. How lucky we are to have scheduled Hughes Melton to speak during Primary Care Week. Celebrating Primary Care Week, the medical students of the Generalist Scholars Program have gifts of apples for all of you as you leave the auditorium today. Reminders of the shared investment and responsibility that patients, physicians, and their community have for health and well-being. And now I'm so delighted to welcome back Hughes Melton and give him to you for the rest of the hour.
Well, it's great to be here. I have a lot of memories at UVA of my 7 years here, 4 journeys. So first, of course, of becoming a physician. Spent 7 years here, as Marcia already shared with you. And then also the journey of my mother through cancer for 8 years. This was about a year before she passed away with my older daughter, who's here. I'll embarrass her in the back of the room, and she'll raise her hand. So she's accompanying me on our trip today. Also meeting my wife during one of my rotations, my very first rotation as an intern, and then getting married 11 months later. So, and then also a much better understanding of my faith, spent some time in Trinity Presbyterian Church. So, these are our learning objectives. Have to have a learning objective slide in there, of course, in the lecture at the Academic Center. So, and you'll be seeing that again as we go forward. We have an hour. You know, what can we really get done in an hour? You know, I hope that some of what we've experienced you can walk away with is some learning tips for the future, and then also maybe some questions that you can ask yourself as you go forward in your professional life. So this is a picture taken when I accepted the award. About this time last year, actually, the new guy gets to get penned this coming Friday. I think actually Megan and I are going down for the trip. But you know, the important thing to recognize is that really it's not about me in terms of the things that we were able to accomplish. This is a picture of our 10-year celebration. So this is our staff and family and everything, and that we have that has grown around what we're all about. This is my Honeacre team. Oh, I forgot to enter that information in there at the bottom of the slide. But did a survey earlier this week. Interestingly, we're always trying to get a sense of, well, how well is the team working together? And on a Likert, 0 to 5, they scored a 4.8 in honest and open communication amongst the team. And as you'll learn later, that is so important to being able to work as a team. And what does that mean for your ability to stretch and serve in a sometimes challenging environment? These are my partners, Dr. Brian Easton. I know some of you know him who have taught here for a while. And then Ann Townsend, who joined us more recently. This is Dallas. Dallas is when I get frustrated working with my patients in substance abuse, I just picture Dallas in my mind. He was born to one of my substance abuse patients with multiple congenital abnormalities. He's got a trach now. Hopefully in the next 9 months going to be getting that taken out. And you know, the likelihood that he would have even survived to this point with a mom who was actively abusing narcotics, very, very small. She's in the program, she's doing excellent, and therefore he's doing excellent. So, you know, I don't know if any of you have watched the U.S. Open. We've watched it this year, and the kids have really gotten into it, and got to love that match with Djokovic and Novak. So what I found in looking back is that a lot of what we were able to accomplish, we accomplished by the fact of my being able to serve in what I call a sweet spot. And you know, looking, I experienced it moving forward, but I really have understood it looking backward and trying to put together my thoughts for today to share with you. So, you know, the question is, how do you find that sweet spot? And there is some trial and error, but mainly I experienced it moving forward and then looking backwards. This is kind of how we started, just the two of us. We met in 1998 in Abingdon, Virginia. Martha Washington kind of sketched out our vision of where we wanted to go with the practice, and we kind of felt like we had it all. Figured out. To be honest with you, we thought, well, you know, we're got all these skills. We're going to go to this rural, underserved area of Southwest Virginia, and they're going to love us. You know, it's going to work great. Well, it didn't necessarily turn out that way. These were some of the initial services we wanted to offer. But what we found was 3 years later, 2 of them were gone. So the hospital had closed their OB department, and because of changes at the family medicine residency here, they weren't able to send their residents. So at year number 3, Brian and I were kind of struggling with what are we doing here? And this is why we came initially. And so we kind of stepped back and said, well, you know, what are we really doing here? You know, are we practicing family medicine, or maybe are we doing something, you know, bigger than that? And so we kind of went through a process to try and understand a broader understanding of our vision. Changed our name. Actually, we were Highlands Family Medicine before that. Changed it to BC Health, with the focus being basically we're about making life better in whatever form that takes. And the idea of us being able to come in and say, oh, we have these services to offer, and that's going to make your life better, it didn't work that way. What we found was that we developed a broader, a different understanding of what service is. And what we found was that, you know, serving is not rescuing. So often what you see on TV is people going to do service somewhere, right? They show up and they meet a need and then they're gone. And yes, that's important. But it's not the kind of serving that we were being called to do in our area. It's much more of a, if you look it up in Webster's, it's actually serving is answering the needs of or to supply the wants of. The challenge is that you never really know exactly what those are until you engage. And so that's what I think of serving as, really engaging a need. It's not an arrival, it's a process, and it requires relationship over time. The other thing is that just like any relationship, once you engage, when you give, you actually receive as much, if not more, back. And that becomes very important when you're in a rural, underserved area, because if you don't receive, if you're not fulfilled, then you burn out. And we see it happen all the time where we are. So the definition of service. So what do we do? Well, when we step back, one of the things we were asked, if we didn't get asked one time, we got asked 1,000 times, you know, are you going to stay here? Because so many physicians come into our area and they do not stay. And so we realized, yes, we had moved into town, we had bought a house, but really what would send the message to our patients so that they would stop asking us that question? Because what problem does that cause in the doctor-patient relationship if they're asking that question? Anybody want to take a stab at that? Trust, exactly. So, and you can only enter into a certain depth of your therapeutic relationship with the patient to the extent that they trust you. And if they are thinking, well, you're going to be gone in a year, it really is a major impediment to building that relationship. So So in response to that question, we built a clinic in the area for a lot of different reasons. By the time we finally got it built, we were 6 of us practicing in 2,800 square feet. We used the analogy of working in a submarine. So we needed a new space, but it meant something different to the community when we actually built our own freestanding facility. Will you care for my sister with no insurance? You know, there is a lot of underinsured and uninsured patients where we are, and there is no free clinic where we are. And so we looked at that problem. We said, okay, well, what is it that they need? We could have tried to start a free clinic, but we felt it was actually better to work to create a system within the clinic to meet that need. So we have different processes by which folks are on sliding scales, or we have a tie-up program where we'll just pay for their care, they get free care. And to meet that need that we really didn't see coming in. I mean, you know it exists, but it's different when you actually get there. Where can I go to lose these 40 pounds? So, you know, a common problem, growing problem, literally. So we're working with the YMCA in Bristol, which is 45 minutes away, to try to bring a YMCA to our area. So I'm involved with that, and the clinic supports that in a lot of different ways, financially as well as others. And then the last one, which has been a big area of fulfillment for me, is the treatment of substance abuse. And when we lost obstetrics, it was a real blow. It was tough because my partner had spent 9 months in Africa training to do C-sections, and I held down the fort while he was gone. We really invested a lot in that service, meeting that need. Well, when it was gone, we went through that questioning process, and one of the things that kind of rose to the surface of engaging the people we've gotten to know in the community is the issue of substance abuse. So looking back, I mean, it's a much bigger issue than the issue of prenatal care and obstetrics in our area. And yet, when we came in, we didn't even see that one on the radar. So we answered that one by starting a narcotic addiction treatment program in our clinic. And we'll talk more about that later, what that's led to. So what did we learn? So we learned that engaging really requires you to change. And you have to change, I think, for 3 reasons. First of all, you're never perfectly formed to meet a need. You may think you are when you initially engage, but once you get to really understand it, once that relationship grows, it becomes something different. And so if you're really going to meet it, you have to be ready to change. The other thing is your needs change. As one of the common phrases, who moved my cheese? Yeah, exactly. Great book, by the way. So, needs change over time. And so if you stop stretching, it doesn't take very long for you to start to become disengaged with the community. And the last thing is you change. And certainly I've changed. So, in 8 years, my kids will all be in college. But that's going to be kind of a new phase of life. I have friends of mine who are kind of going through that right now, and it has major implications for how they spend their time and what they do. And so as you change, you have to understand that that's going to change the way that you can engage the need. So you have a choice. That's the way I look at it. It's definitely a choice. I think often physicians get lulled into thinking they don't have a choice. But you do. You really do. So you can either not stretch when you engage, and unfortunately that results in superficial engagement, and most of us are familiar with individual marital engagement types of relationships, and if you do that, it doesn't work out very well as a general rule. It's the same thing when you're in a community. And if you aren't engaged when you give, you may or may not receive, because what they're experiencing on the other end is not necessarily what you think they're experiencing. So you may think you're giving and they should be receiving, but they're really not receiving, and therefore you don't get much back in terms of fulfillment. So 2 things I've seen happen in our area: folks either disengage, so they either move move to try and find a better fit, or they're not really that involved in the community. You know, they come to the clinic and they do their 8 hours and then they're gone. And the patients tell you about that because they leave those physicians and will come and talk to you about it. To try and, of course, they try and find a better fit, but often that's elusive. And so they'll get to another location. Sometimes it's a better fit. I mean, if there are just things that you can't stretch to, and there are things you can't stretch to. I mean, you have to ask those kinds of questions. Or they burn out. And so we had a physician leave last year because he burned out. We have a physician, right, not in our practice, but in the community, who we're working with the local hospital, and she's, you know, this close to leaving because she basically says, when you lose that fulfillment, and you've got nothing left, you're tired, worn out, why am I here? Then you start to tune out the need, and it's like a death spiral almost, or it's a term used in aviation where, you know, it's I guess a vicious cycle that it just gets worse and worse and worse, and it can get. Mostly they will usually end up leaving. Sometimes they get out of medicine altogether, depending on where they are in their career. But since we've been there for 10 years or 11 years, 12 physicians in Russell County, come and gone. It's almost a tragedy to see it happen sometimes, both to the patients in the community as well as to the physician themselves. Or you can choose to stretch. So engagement, bringing reception. You know, there's lots of kind of quotes out there about what is it that you receive when you really connect. So that's what I recommend. That's where we kind of came up with the idea of stretching to serve. If you're going to serve and you want to serve, and most of us do, that's why we went into the healing professions, then you need to choose to stretch. The other thing is things change. So in healthcare, 5 years, what you learn, it's obsolete, right? So if you're not continually stretching and changing, then you're going to find yourself obsolete. And that's a challenge in a rural area. You know, that's one of the nice things about coming back here. It's very intellectually stimulating just to walk through the halls at UVA, you know, and you have to find that a different way when you're in a rural area. So I think of it as kind of a protective factor. So this is one of my patients, my pregnant patients. We have a lot of pregnant substance abuse patients, interestingly. So I think they select our program partly because of the way that they are treated, and I think partly they get referred to us by other areas as well, some of the other health systems, the community health system near where we are. So if you had told me when I got there, at 3 to 4 years old, you told me when we lost obstetrics that in 2 to 3 years I would be receiving a lot of my fulfillment from treating patients who were pregnant, addicted to OxyContin, I would have laughed. I mean, others I would have been like, "You're crazy. There's no way. I'm not interested in that." But I changed. So with great results. So we're talking about serving to stretch. So how is it that we can make stretching less difficult? Because it's not easy. I mean, we all recognize that change is hard, whether it's change in an organization or change right in here. And so I want to talk about kind of two variables or two things that will make it less difficult. It's definitely still not easy, needless to say. So if you can maintain your fulfillment while you stretch, that's the key. That's the key. And I think you maintain fulfillment through two basic areas. Fulfillment fundamentally, I think, comes from the work that you do on a daily basis, your technical work, however you get it, internal fulfillment as a general rule. And then also fulfillment by virtue of who you're doing it with, your team that you're working with, your nurse, your colleagues, whoever that may be. And so those are your two sources of fulfillment as you move forward. And so you want to maximize those. So let's talk a little bit about intentional altruism. And you'll understand what that means as we get into it a little bit more. But simply stated, it's understanding that you need to be able to keep foremost on your mind what the values and beliefs you are that you hold most deeply. Easily said, often hard to do in the day-to-day craziness of life. So, 2 factors. When I first saw that quote by Shakespeare, I didn't get it, to be honest with you. You know, and when I started working with the substance abuse population, I got it, because they can be a very frustrating group of individuals to work with, as many of you, I'm sure, have interacted with that population. And the key is to understand where they're coming from, to understand that addiction is a chronic relapsing disease, for example. So if you believe that they're out just to get you and make your life difficult, then it's going to be bad. Okay? If you believe that they have a chronic relapsing disease, and not that they didn't make bad decisions, they made bad decisions, we all make bad decisions, okay? You know, but that it's a chronic relapsing disease, it really helps you to step back and go, okay, well, that helps. You know, do you get mad at your diabetic when they don't take their insulin the way you tell them to? You know, maybe a little bit, but not this kind of mad when a substance abuse patient is trying to dupe you into giving them their drug of choice. So that's where kind of their perspective comes in. Any runners in the crowd? Who likes to run? Yeah, any kind of athlete, you know, athletics. You know, yeah, there's pain, right? If you hate running, it's really painful and you suffer, right? If you love running, if you value what you get out of running, right, then you don't suffer, right? Another more humorous way to look at this interplay between what you're thinking and what's happening emotionally and what your desires are is this.
Here's the deal. Marshmallow for you. You can either wait, and I'll give you another one if you wait, or you can eat it now.
My daughter knows iMovie better than I do, so she actually worked on that on the way up last night, because it's a 3-minute video and that was way too long, so we had to pare it down a little bit. But, you know, it's funny, but was it funny for them? No, man. It was like agony, you know? That wrestling with those kinds of, you know, should I eat it now? Should I not? My parents going to be mad. My mom's going to be mad at me if I get to 1, you know, and didn't wait to get to 2. And so this kind of a summary. And, you know, the problem is that if it were that easy, then it wouldn't be a problem. But it's not. It's hard. So a couple case studies to try and make this like real, right? So when I came to med school here, right, I lived in a house with 3 other people, no names, but I understood that, you know, I'm probably, well, that's me doing that, sorry about that, that I'm not going to be getting straight A's. Okay, I just knew that from the beginning. So most of us have heard of the B equals, or C equals, yes, classic is C, but I think, well, that's like kind of a cop-out, you know? I mean, come on, you can probably at least average a B, you know, maybe get C in histology or something, you know. But yeah, well, I had one of my roommates, it was all A's, you know, and that's what she expected, and life was really hard for her because she couldn't do that. And so it set up that conflict. Another example, interestingly, about a year and a half ago, I applied for the Sorensen Institute. Many of you know the Sorensen Institute. Is a program here that is excellent, very good, and so I applied, and I unfortunately allowed myself to start thinking that, well, I'm really competitive. You know, I probably would be able to get into that program, right? And I slid, or I drifted, which we'll get into that in a second, into this kind of a unconscious, you know, I'm going to get in. Well, I didn't. You know, so I call that my Sorensen denial. It was a real wake-up call to me of, you know, you need to be careful about what your expectations are, what expectations you allow to develop inside of you. Now looking back, it's great I didn't get it for a number of different reasons. One, within 4 months I had gotten selected for the AFP award, which had quite a bit of responsibility, and it would have been a lot of time, which I probably really didn't have to do the program as things kind of progressed. Would have had to say no to some things I didn't want to say no to, so it was a good thing. Right. So substance abuse, diabetes, and staff, we kind of talked about that with my staff. Boy, the patients who have substance abuse will drive them crazy. So I'm always trying to remind them of, you know, you have to understand it's a disease. You know, the patients aren't doing it just to make your life miserable. It's just the way that they think. And then lastly, methadone, you know, when you talk about how your thinking affects not just your emotion, but also your drives, you know, your actions, your behavior. I was approached, I guess 2 years into being in Russell County, to help start a methadone clinic. Methadone. Now there's a loaded word for you. You know, I mean, there are all kinds of beliefs and feelings stretch across the map when you mention the word methadone. Well, my immediate reaction was, you've got to be kidding me. I have no interest in that whatsoever. Got a family practice. We're doing great. Methadone is a poor substitute for a street. I mean, all the stuff you hear about. Well, a year went by, and they reapproached me through a friend of mine at the hospital, the CEO. So I said, well, all right, he's asking me. I'm going to really kind of do a little research. So when I stopped and studied methadone, I actually found that done right, used properly in the right clinical situation, it actually has some wonderful data associated with it in terms of outcomes and treatment. It's often abused, unfortunately, in a number of different ways. But my belief, when my belief changed about methadone and what it really stood for, my interest, my desire, and maybe being part of that changed, as you might imagine. So like I said, if only it were that easy. The problem is that of something that I call egotistical drift. And this is where, again, we get into talking about intentional altruism. So you can say, yeah, I want to get my thoughts on altruistic thoughts and keep my vision clear in my mind. But the problem is that, as a general rule, we either tend to think altruistically or we tend to think egotistically. And so where do we start when we're born? To the right. Yeah, egotistically, right? Yeah, give me my bottle, I want it now, you know. And we gradually, start to move to the left. You know, nobody stays all the way over to the right, as we get older. At least most of us don't. And so, but the problem is that if you don't intentionally do things, which we'll talk about, I believe all of us pretty much drift to the right. And that sets up issues. So where's he? Yeah, he's over to the right, you know. So you run into this sort of dynamic. And a couple things will happen to push us that way. Partly, I think, for a lot of us, for me, I'm not going to say for you, but for me, I mean, I have a tendency to start thinking, this isn't good for me. There's some things that really aren't good for you, obviously, you know, but I start thinking me, you know, instead of we, ours, as you saw earlier. And external events, external messages, I mean, we're constantly being bombarded with very egocentric messages from our culture a lot of times, and also for events in our life. So a year and a half ago, this past April, I was in a malpractice suit. Spent a whole week in court. And it was misery. I mean, it was an experience I would not wish on my worst enemy. And when you get into a kind of a survival mode kind of situation like that, it drives you, it will tend to drive you to the right. And I think that's part, I certainly wouldn't even think to speak to what it's like for other people, but for me, that was part of the damage done by that experience that I had. So there are different ways to try and prevent that. So if you just leave it to external events, that happen, to try and refocus you on what you're really about, what your altruistic vision is for your life and for your career, it's just going to happen episodically. And that's good. Holidays, remembrances, this is the 9/11 memorial, as many of you recognize. Okay? Those are good things. But the problem is that I would argue that they are not enough. And if you just allow the external forces to try and remind you of what's really important in life, then it's not going to work for you. So I heard a story last week, there were, of course, news coverage, and somebody from the, who was in the Bush administration at the time said a bunch of the staffers took out of one of his talks a line that he said, which said, I can find it here. We will not tire, we will not falter, we will not fail. And they cut that out and they put it on their door or desk or wherever as a continual sort of reminder. And that's the sort of thing that I thought, that's kind of what I'm going to be talking to everybody at UVA about next week, is that idea of being reminded regularly. So just another way to talk about it. Or Dallas. Dallas reminds me. So when she comes in and tells me how he's doing every month when I see her, it's a grounding experience. And I recognize that now. If you'd asked me if 5 years ago, it just happened, and I didn't really understand what was going on up in here. Now I understand what's going up in here, and I can actually look for those. And if I'm not getting enough of them, then you can say, okay, I'm starting to lose my joy. So that's where we get the term intentional altruism. You need to be intentional about reminding yourself what is your long-term, hopeful, transcendent vision, your values, whatever you want to call it. I'm not going to label it for you. It's different for every person. But I would just argue you have to be intentional about that. If you don't, you end up down here to the right, and it's self-destructive. That's a great quote. We just do that every night before we go to bed, right? That would help start off the next day. So how do you avoid the drift? Theoretically, look for it, recognize it. That's probably straight out of a textbook somewhere. I'm making up with it, but it sounds like it's out of a textbook. In reality, I think that there are two places: internally and externally. So internally, you can have your regular time, whether it's your coffee in the morning at Starbucks, reading the paper, thinking about, okay, what am I going to do today? Whatever it is for you, I would just argue that it needs to be regular. And then also, kind of appreciative inquiry. I think that's a common term, common concept nowadays of taking time to do that and trying to step outside of your preconceived notions. That's important. You need to do that. I do that. It helps. It helps me keep focused internally. But I don't think that it's enough. For some people it is. For me it's not. When I ended the malpractice case, I had no joy in my technical work. Every patient was just another potential suit. I really did not want to go into work the next day. And so what do you do when that's the case? I mean, it's going to take time for me to heal from that and to kind of get the joy of seeing patients back. That's where the second thing comes in. And that's the external piece of what I would call team accountability. And that's where vulnerability comes in, which is important. So there are a lot of benefits to being on a team. Let's go back to this slide just so you kind of know where we're going, because we're kind of going all over the place. So now we're into kind of what I call necessary vulnerability and fulfillment in teamwork. So lots of benefits to being on a team, right? We've all read about it, heard about it. You know, it's like the mantra, especially here the last 5 to 10 years, you know. Increased efficiency, accuracy, productivity, you know, safety, I mean, it's all out there. But I don't hear what's talked about very often as one of the major benefits, and that's what I think would be increased fulfillment. And I would argue that that's probably one of the most important benefits to a team. So, what does the team do? How does the team help you with fulfillment, right? Well, it does two things. I think it reorients you and it rejuvenates you. So reorientation, you know, as other members, as you start to stray, you come in, you had a bad night, didn't get much sleep, on call, whatever the case may be, you know, you come in, you're grumpy, you're tired, oh, I got a room full of, you know, all 5 patients already ready to be seen, right? So chances are, everybody on your team is not having a bad day. And they'll look at you and they'll say, what's wrong, Dr. Melton? And I'll say, oh, okay, they will help you subtly and sometimes not so subtly to reorient yourself to why am I here? You know, the patient in that room I'm going to go into doesn't know that I had a bad night. It's not their fault. And really all I have to do is say, you know, why am I here? You know, it's not about me. Yeah, okay, I'm going to need to catch up on my sleep. You know, you can't just ignore that. But let's refocus. So we talked a little bit about malpractice. You know, substance abuse, when they push your buttons, your team will help you out. And when you're really frustrated, you can go from being frustrated to laughing about a situation when they just kind of rephrase it for you. So how does that happen? We have a morning team huddle. We have monthly clinic meetings. This is our kind of team huddle. This one was Tuesday morning. I asked them to let me take a picture. They weren't very happy with me, but they let me take it. So this is in Honecker. We just get together and kind of touch base, share concerns, remind us of what we're there for today, look at the schedule. That's kind of the stuff gets kind of put out in a message that gets sent out to everybody. Everybody doesn't make this meeting, obviously. Some people up front answering the phone. But everybody hears what happens through the messages that we send out in the clinic to everybody. So anybody want to take a guess at the blank? Starts with an L?
Love.
Man, you were thinking it. Yeah, exactly. Exactly. And that's what happens within the team. I mean, love's a loaded word, okay, friendship, whatever you want to call it. But that's what happens in that team environment if you get the team environment. It also rejuvenates. So there's something about a wounded teammate. You know, if a teammate comes in and they're not doing well, it's like it's human nature. You know, if you have a team that cares about each other, they pull together and lift that person up. Often I find that when I've been gone now for a week at a conference, so like when I've been gone most of this week, I'll come back. Really, the thing I'm almost more looking forward to than my patients on next Tuesday morning is seeing my teammates. How was their weekend? How are they doing? Yeah, that's reason enough. So vulnerability. I hope you're asking yourself, well, what's necessary about vulnerability? Well, you can't build a team without it. And that's why I think the whole team-based learning that's happening now in medicine is so powerful, because the students who are getting exposed to that now get this. And when they get out into practice, they're going to be able to, they have a much better sense, I think, of how a team ought to function and communicate and with each other. So, yeah, in order to have teamwork, you got to be honest. Having that kind of discussion takes trust. And to build it, you have to be first. And that's what I would tell you as physicians on a team. Usually it's not a bunch of physicians. In med school it is. But when you get out in practice, it's you and other healthcare providers. And the physicians have the opportunity to lead in this regard, to build that team. And so if you're willing to be first, to be honest, that takes courage. And I think somebody said low up there, right? That's courage, all right? Because you're making yourself vulnerable when you go out on a limb to be honest about the way that you feel. And the other thing is when another teammate shares something, they're putting themselves out there. If somebody else on the team kind of jumps on, you need to be ready to defend them, as you're going to be in a leadership kind of role, which I hope that all of us would want to be. So that's where the necessary vulnerability comes. You have to be willing to be vulnerable in order to create the kind of team that's going to result in fulfillment. And I don't know if any of you have read any of Patrick Lencioni's work, but this kind of just talks about the development of a team and the role of the leader. So the very first thing you have to have is trust. What we found where we are is once you get that, then the other things are really pretty easy once you have that trust. So we survey our team in Honecker, open and honest communication, 4.8 out of 5. I'm excited about that because that's the foundation for then being able to really have honest discussions, solve problems with the collective intellect, all the other benefits that you hear teams talk about, or talk about in teams. Not a team. All right. More like a team. So working together, and it really is a lot of fun. Now, it's not fun every day. I'm not going to stand up here and say I love work every single day. That would not be realistic. But in the big scheme of things, we love it. We've been there 11 years. We're not going anywhere. I think I'd like to think, and I think I'm right, that if you asked the other team members on our team and the other physicians, they would agree. So kind of a summary. And then I couldn't leave that out. Following the news. So that's a research study done by the Department of Pediatrics. So it works for me, and I hope that it might help you. Thank you.
Thank you so much for a wonderful talk. We have some time for discussion with you, comments, and questions with the audience. And I know there are people you know and who know you here in the audience. So some of this can be some homecoming conversation perhaps, but I think you've given us some nice things to think about. This was home for you for 7 years, but it does indeed sound as though Southwest Virginia is now home for you in a very intentional way, and it's lovely to have you back and sharing that sense with us. So comments and questions? Where is it again?
Right here.
Okay. So please tell us who you are.
Hi, I'm Dr. Phyllis Koch-Sherris. I'm a clinical psychologist in private practice, and I've had a solo practice for many, many years. And it's difficult to create a supportive team when you're in solo practice. And I just wonder, I've tried a few things. I have a supervision group that we meet once a month that helps a little bit. I do some co-therapy. I just wonder, what other kinds of suggestions you have. I belong to my national organization. I'm actually incoming president of one of the divisions, but it's the day-to-day thing that I think is the real challenge. And I remember coming out of a session with a group session and saying to my co-leader one day, "Oh my God, my heart just isn't in it. Something is just missing," and not knowing really how to get that back. So I wonder what suggestions you have for those of us who don't have, this big center to be a part of.
Right. Yeah, it's tough when you're in, because my guess is you have, what, 1 or 2 other staff, right? Is that, or?
Basically, it's just me.
Yeah, that's tough, and so, in reality, I think the teamwork fulfillment at work, probably that's not an option for you. So trying to develop that outside of your immediate work environment, it's almost like, how do I stay plugged into what's really happening out there at the frontiers of medicine in a rural area in Southwest Virginia. And so I most recently have gotten kind of involved with the American Academy of Family Practice Foundation. And so I'm finding, interestingly, that kind of group helps me stay plugged into, it's kind of a team that helps me stay plugged into what's happening in medicine, or in family medicine. So, the idea of trying to develop a professional group of folks that you get together with kind of regularly to kind of revisit why you went into it in the first place. And I'm not sure how you would find that, but I think that, and the other thing I guess I would say would have to be you'd have to get together somewhat regularly, because you have to get to know them and trust them and share what's really, this isn't doing it for me. What are you guys doing when you ask yourself that question?
Yeah, I think once a month isn't enough.
No, especially not initially. Now maybe weekly for a month or two, and you build those, and then maybe less frequently or that sort of thing. But no, I would agree, once a month's not enough. Thanks.
Hughes, Gene Corbett, colleague and friend, and nice to see you again. Thank you for articulating such a wonderful message that I think touches us both personally and professionally. And you do it so well. I'm curious about something. And it is to this, what would your reflections be on medical education in retrospect?
Right.
Because I think that the ideal most of us hold, and as you described it today, fits that. Looking back on it, do you have any suggestions on how we can build a little bit more of that kind of experiential development into medical education, beginning with medical school?
Right, absolutely. Great question. Because I think there's already been a lot of work done, just in what I've talked with Chris Burns. Is Chris here today? I've talked to him oh, excellent. Hey, good to see you. So we've been talking back and forth by email, but hadn't actually seen him. So about what's happening with team-based learning in those first 2 years of medical school, and I think that is very powerful. And so for me, when I came through for med school, it was brutal. There were things being done at that time, even introduction to clinical medicine and that sort of thing to try and, but really in terms of a functional supportive sort of team, it's happened for some people and it didn't happen for others. It wasn't as intentional as I think that it is becoming, which I think is important, and I think will continue to become. I don't know if that's really answering your question. I guess, if I had to pick the internal revisiting your values and kind of keeping that straight, or the teamwork piece, I would argue that the teamwork piece is where medical education needs to focus, and I think is focusing on intentionally developing that.
Yeah. So there's this interesting continuum between the altruistic and the ego-centered, right? And where we spend our lives on that continuum, I think, is the personal side of it. And I guess to some extent, my question is, are we not modeling it well enough on the altruistic end, given our struggles with profitability and clinical productivity, and publications? What's your posterior reflection on that? Because you grew up here.
No, I think it was modeled. How well it's modeled varies from mentor to mentor, so to speak, or your interaction with different professors as a student. I think I was very fortunate to have that modeled for me very well, and so it's modeled well, and I think you come out of medical school fairly well grounded in that area. The trick was that I wasn't taught that it's not going to just happen. So when I left this environment where you're bumping into the Sues and the Dr. Barnetts and the Jeans and you're on a daily basis, it just kind of happens. When you leave, It's not going to necessarily just happen. And so maybe, I guess, more purposeful instruction about, hey, you need to set the conditions for this when you arrive to wherever you were going outside of especially when you leave residency. Most residents, most med school residents, I mean, the School of Medicine is intentional about doing exactly what you're talking about. I don't know that they were that intentional about making sure I understood that I was going to need to be intentional about it when I got out, I suppose. So, and how, if you told me that at that time, whether I would have listened, I don't know. I probably would have listened to you and Sue and Dr. B, because that relationship was there, and that's probably where it would have to be communicated.
Dr. Melton, my name is Doug Wilson. I'm a pediatric intensive care doctor here. My image of a family practitioner in Southwest Virginia is 24/7, 365 days on call, particularly with a large patient population with drug abuse problems. How do you set boundaries, and what is your life like when you're home?
Yeah, great question, great question. And there's some truth in that. I mean, obviously, to any stereotype, there is validity, some truth to that, And those are the folks, they leave in 2 to 3 years. So for me, one of the things that we were very purposeful about in our kind of vision for the practice was we were not going to let that happen, Brian and I. And I will give him credit for being much wiser in that regard and as to the need to protect our life. So, with boundaries, we all have boundaries with any of the different relationships in our lives, and so how to capture that. Probably the main thing is, and one thing we're not taught very well in medical school, is how to say no. And because it goes against the grain of wanting to help. Usually if somebody's asking you, they're not asking you to hurt them, they're asking you to help them. And so when you say no, the way we're programmed is, I'm not going to help you. And so if you have to get away from that and be willing to say no, because when you say yes to that need, you're saying no to something else. If you're busy, probably no to your family and no to your home. So they're practical things. We limit our panels to 1,800 patients. When we would take call a week at a time, we spread that out. So luckily Brian and I started together, so it was every other week, which was survivable. There's a guy in town, he's been there for 20 years, he takes call every week. He lives the life he lived, he still lives. I don't see how he lives, but, and then as we grew, of course, it's every 3rd week, every 4th week. And so you have to, he and I are intentional about, how we meet every week, every Thursday, say, how you doing, what's frustrating you. And so we have that back and forth ability to say, I'm tired. I need to get some rest. So you have to be intentional about it. Otherwise, the need will consume you. Even if you can stretch, if you don't maintain the other areas in your life, because this is just off a professional, then it'll burn you out. Did that answer your question?
Yeah.
Yeah. You bet.
That was my question, but I will vary it slightly.
Yeah.
I'd like to think of the relationship between egocentrism and altruism as a necessary tension,
Excellent.
okay,
Yeah.
rather than an attempt to polarize it one way or another. If you're able to accept that as a necessary tension, then you can deal with some of the frustrations that come along the way. For example, the patient who refuses to get better and makes you hate him, and how you deal with your own internal experience of that hatred.
Right.
If you do it well, it will release love, but that takes time to cultivate.
Yeah, it does. It does. And when I say altruism, one of the altruistic goals can be that I will be healthy. You're exactly right. You can't live a life completely for things other than just you. It's I like the tension perspective. And I've found that when I've gotten into that place where the patient is just pushing my buttons, course, you have to kind of disengage when it gets to that point. That's where the team can really help. So if a patient comes in, she goes, yeah, I bought some drugs, but I didn't take them. I said, well, that's good. You know, great. Where are they? Oh, they're at home. I was like, what do you mean they're at home? She's like, well, I can't throw them away. I bought them. You know, and so I'm like, I mean, that's a kind of a comical example, but you just want to cry to laugh, you know. And so I shared that with the team, and we were all just laughing, just shaking our heads, you know. Whereas it could have been a real point of frustration for me, you know, that she hasn't even progressed that far to recognize that that was a bad decision to keep that. It needs to go down the toilet or in the coffee ground.